Hi, I'm Ralph Preston. I have Stroke Buddies, and on Tuesdays we have these meetings where we try and bring you recovery and science information. And today we have a little of both because we have Dr. Samantha Amadeo, who's a neurologic physical therapist, and her presentations are always well received because she's full of good information for us. And that will definitely be true today because tone and spasticity are big issues for all of us stroke survivors. So let's let Dr. Sam do her thing. Welcome, Sam, and thank you, thank you, thank you.
Of course. Hi, everyone. I'm so excited to be back. Um, this was a topic that me and Ralph discussed last time. I feel like it always comes up in all of our previous podcasts that we've done together. And after doing a poll on the Stroke Buddies Facebook, it was definitely well received. So that's why we're here today. Um, so we'll definitely make sure that we continue to do some polls to get the information that you want to learn about from me and from Ralph. So I'm going to, without further ado, I'm going to share my screen. I have a small presentation just so we kind of keep on track with the way that I can best explain tone to you. So just give me 1 second. I'm going to share it now. And if you guys have any questions along the way, feel free to, just unmute yourselves and let us know. And then if Ralph, if you see the chat, if you can just kind of manage the chat, that would be great. Just because I have the whole screen up and I won't be able to see it.
Gotcha.
Okay. So got tone, kind of like got milk. That's where I got that from. So got
Funny, I
tone,
thought
I
the same
discovered
thing.
that's kind of where that little name came from. So Gatone, we're really going to figure out what it is because it is sort of a mysterious thing, and then really how we can work through it and ways that both, your medical team tackles tone, but also things that you can do at home. Okay. If you hear any snoring, it's because I have a little doggy that's laying on the floor next to me. So I apologize for that. Okay. So first we're going to go into a little bit about me again. We'll go through what tone is, so normal baseline tone that everybody has, then kind of what tone looks like after stroke, how tone can change, and then how we can manage tone. So again, I'm Dr. Samantha Amadeo. You can just call me Dr. Sam. I'm a physical therapist and board certified neurologic clinical specialist. I have been in all different areas of physical therapy, from the hospital, rehab centers, working with children and in research. And I love teaching, which is one of my favorite things about, Stroke Buddies, is I'm able to not just teach other clinicians, but I'm able to educate survivors. I developed NeuroThrive, which is my practice, for both being able to provide, because I'm located in Staten Island, New York, I can provide home care and virtual physical therapy treatment for people who are within New York State, but then also to expand access to care for people who, don't have good access to neuro rehab through exercise programming and rehab coaching. So if anyone is interested in working with me, I would love to chat further. You can chat with me after this, or we can discuss over Facebook. But yeah, that's just a little bit about me, and let's dive right into it. So, in general, everybody has some sort of muscle tone. This is a typical thing that we see in just human anatomy in general. And what it is that we have within our muscles, each of our muscle fibers, they have a crossing of fibers. So you have this fiber and that fiber, and they cross over a certain amount. And that crossing over gives the muscle a minimal form of contraction at rest. So if you feel your arm, if you have hemiparesis, feel the unaffected arm, you could feel your bicep has a little bit of stiffness, right? So it's not just jiggly, right? It's not just mush. there's some sort of a resting contraction to that muscle. And what that is some of the muscle fibers are, well, all the muscle fibers are somewhat overlapped at rest. So this muscle tone provides us with good postural control, with our balance. We have to have some sort of underlying resting tone in all of our muscles just for normal function. So this also puts our muscles at a good position to contract and relax as needed. So if our muscles are too overlapped, so in hypertone or contracture, and or even just position wise. So if my bicep is in this position and the muscle fibers are too overlapped, I'm not going to get the same strength in this muscle as I would if it was at an optimal length. Same thing if it's overstretched. It's way harder for me to contract the muscle if my arm is straight or if I have flaccidity or lack of overlap in those fibers if they're too far away from each other. So they kind of need to be in this optimal position to get a good contraction. So that's with anyone. All humans have this. So it's typical to have a regular form of muscle tone.
So
Specifically, yep, go ahead, Ralph.
so is flaccidity the lack of overlap? I mean, I know it's a lack of almost no tone at all.
Of flaccidity, yes. So it would be the lowest form of tone where we don't have any overlapping of that musculature.
Okay, thanks.
Um, and also because you're not getting the signal to the muscle is so low that it's not giving it any information to contract. So you're really at the farthest distance from that muscle having any underlying tone. So for instance, when someone really the arm just kind of hangs, right? So if you're thinking about a flaccid upper extremity, the muscles are really stretched out and just relaxed completely. So there's no baseline tone at all in that muscle. And you'll see, Ralph, I included the Brunnstrom stages here too. So that's right at the bottom where you have your tone at the lowest amount.
Yeah, I was thinking about the Brunnstrom stages, of course.
Now, the Brunnstrom stages, I mean, we're going to get to it, but it
Ah,
actually is a principle of recovery where it's more of like a theory of that this is how things typically go with stroke, but it doesn't necessarily mean that this is exactly the way things go. So some people work through the stages of Brunstrom and some people don't. So it is a really interesting concept. And I think one of the things that we learn as physical therapists and things that you probably have felt as being on the receiving end of therapy is a lot of our answers to questions are it depends. It's never straightforward, unfortunately. But also at the same time, that kind of makes it fun because it's all so individualized. So it really depends on the person. Um, and everyone's experience following stroke is going to be different. There are a lot of things that fall within the same path, like the Brunstrom stages, but many that do not. And that's kind of where the questions and the problem solving come in. So when we have underlying tone, we or contraction in a muscle. In order to get some sort of voluntary movement, we have to be able to control relaxation of a muscle and contraction of a muscle. So there are what we call antagonist muscles and agonist muscles for movement. So for instance, if I want to bend my elbow, right, the main muscle that's going to be bending my elbow is my biceps. But in order for me to contract my biceps, which in this scenario would be the agonist muscle, I need to make sure that this muscle is relaxed. I need to make sure that my triceps is able to relax and stretch so that my biceps can contract. So these two muscles are going to work together in sort of like an opposite relationship where they're not fighting against each other so that I'm able to get smooth movement into this direction. And then when I want to extend my arm, my bicep knows I'm going to relax now so I can let triceps work. So this relaxes and then this contracts to extend the arm. So that's an important balance that we see between tone, because if say your muscle fibers are always tight, so this muscle here, your biceps is always tight, how is it going to let triceps do its job? Right? Because it's never going to give it the ability to contract because it's pulling against, they're almost fighting against each other, which is something that we typically see when people have higher tone following stroke, is that you will have weakness not only because of your hemiparesis, but because you're fighting against the contraction of a muscle that has high tone in it. So you may just have, you may even have the ability to use your triceps, but because of contracture, which is, an actual shortening of the muscle fibers because of maintaining a specific position for a long, long period of time, you may not be able to just get that range of motion because of tightness of a muscle or high tone of the opposite muscle. I included here that for those who have lower body also affected, we may see this in quad and hamstring. So quad being the front muscle of the thigh and hamstring being the back muscle of the thigh. A lot of the times we'll see tone in either of those muscles, so that during ambulation, so when you're trying to walk, a typical thing that we see is our hamstrings may be tight, which will limit our ability to kick the leg straight. So you'll feel tension in that hamstring, and because of that higher tone in hamstring, the quad can't contract optimally because they're fighting against each other. Even sometimes with flexing. So some people have difficulty like descending stairs or sitting down because the quad is so tight. So it's keeping the knee in extension and doesn't let the hamstring take over. So that balance between relaxing and contracting is off following stroke. So with tone and stroke, I mean, I kind of have been touching on this as we go through, but we can see because of the damage to the central nervous system, this balance or tone at rest is impacted. So I want to call hypertonicity and hypotonicity, so high tone versus low tone, specifically resting tone, because when we lead more into spasticity, which is a word you may also hear, it's actually different than just resting tone, because you can be completely good at rest, normal resting tone, but spasticity is when you introduce a quick movement or speed to a stretch of that muscle, that the muscle resists that movement. So you don't have to have high resting tone to have spasticity. So if you all have been evaluated by your physicians, your physical therapist, your occupational therapist, they may just do general range of motion where they ask you to bend your elbow, they measure, they ask you to bend your knee, they measure and extend. So that's really just at rest. But if they do a quick movement to see if there's like a catch in the muscle, that's spasticity measurement. So they're a little bit different. And spasticity is really something that it doesn't really impact you at rest, but it's going to impact if you're trying to do some sort of voluntary movement. Or for instance, there is a passive stretch to your muscles that just happens during a movement. So sometimes what we see is spasticity increasing, so a high tone in a muscle during walking, because what can happen is when so this is kind of going back to our last conversation about gait impairments, but when we're moving in a stance phase of our walking and we're going into our foot's flat in the floor and our foot's flat on the floor like this, and our tibia, so that the lower shank of the leg is moving forward over so that we're weight bearing and shifting through, we're actually stretching the calf muscle, which can turn on tone, and you can get a clonus or you can get a pushing happening. So that's something that people really sometimes struggle with during walking, is as they're going through their stance phase, tone kicks in because we're stretching the muscle. So sometimes there are movements that we do in everyday life that increase tone as well, which would be more so related to spasticity. But kind of going back a moment to resting tone. So following stroke, there are kind of levels of high tone and low tone that we can expect as both survivors and therapists to see in patients following their stroke. So me and Ralph have been mentioning the Brunnstrom stages of stroke recovery, and they're kind of numbered, but I really just like to think of it as a bell curve of recovery and putting it as like a measure of time. So typically in the very, very early stages of stroke, so just think when you first see any type of stroke symptoms. This could be even before you um, are in the hospital. You see flaccidity or lack of strength. So completely like a dead leg or a dead arm where you can't move. There's that paralysis there. That's low, low tone. That's as low as we get. That's flaccidity. So with time, the most acute of a stroke is typically flaccidity, low tone hypotonicity. As you recover through time, so if we're thinking in this direction is time, typically what happens is tone increases. So as the as time goes by, recovery, neuroplasticity, all these things start to happen within the brain, tone starts to increase. And it can get to a point where it hits its peak. So where it's the worst it possibly will be, which for some people could be a little bit, and for other people could be complete tightness that we cannot even stretch. So the type or the amount of tone can really fluctuate, but people usually hit a peak. Once you're at that peak, tone starts to come back down and we recover to normal balance of tone. So it's not, oh, we're losing tone. We're losing the pathologic tone, I would say, where we start to get better control of that balance of agonist, antagonist muscle, or being able to increase tone of a muscle and decrease tone at our will versus it being involuntary stuck. Passive range is really, really tight. So thinking of it as that stage of recovery as like a bell curve, you may be thinking yourself, okay, I remember back when I was first in the hospital, my arm was just dead. I mean, Ralph, you could probably speak to this, right? So right in the beginning, like you really don't have much movement and you can see that you start getting tight over time and then the tightness reduces. So that's a very common step-by-step function of how the body recovers following stroke. However, this doesn't mean everyone's going to go through all stages. Some people stay at flaccidity, unfortunately, and they never get any tone back. They're completely paralyzed in that arm or in that leg. Or in their face, you can have drooping face for forever following stroke. Some people start building up tone and they stay there and they stay tight for a long, long period of time. These are people who you see walking on the sidewalk and you're like, oh, yep, I know they had a stroke because you can see them in that posturing of high, high tone in their arm or their leg. But as we move through these, our goal in, everyday life and in therapy is to not only improve tone, but work with it as we move through recovery. So the thing is, I mean, once we go a little bit further and we go into like ways to improve tone, sometimes I always warn my patients that underneath tone, there's weakness because the muscle hasn't been actually used in a very, very long time. So it's almost like you have some fake strength there because the muscle is so tight involuntarily. So some people, like I work with a patient right now, she's got very, very tight quads because of tone. And it actually helps her with going down the stairs because the muscle is so tight, it slowly lowers her as she comes down the stairs. Now, because the muscle is so tight, it can only flex the knee so slowly because it takes time for the knee to relax because of the muscle tightness. If we took away that tone, she'd have complete weakness and collapse on the stairs. So right now, she's actually doing really well with doing her stairs, but as she goes through her recovery process, we may see a regression in her ability to do the stairs because tone is decreasing and the weakness is showing itself more. So there is benefits and I guess cons to having tone at certain points. I see, Paula, you have your hand raised. Go for it.
Sure. I think that's an important point. I've heard a lot of people whose doctors will give them botulinum toxin injections in their quads and hamstrings, and then they lose the ability to walk for that very reason. And I think that's a really important point for people to understand.
Yeah, for sure. Thank you. Um, it's interesting because you sometimes be most of the time tone is thought of as a negative thing, but we can really take advantage of that tone. Like for instance, if someone has some pretty tight tone in their leg, we're getting good stability because we're actually getting a contraction of the quad or the hamstring. Um, or even the ankle, they're getting a little extra stability. It's almost like you have an internal brace on your ankle, not letting it move. So, even if voluntary movement is a little difficult, you're getting stability where we can actually get some good stepping practice versus if your leg was completely hemiparetic, completely paralyzed, you wouldn't be able to bear any weight on it. And we would be very, very limited in our ability to walk with you. So, understanding like kind of what you can do at different parts of your recovery is obviously very individualized and unique to the person. And obviously, with your therapist or whoever you're working with, you can kind of go through those things. But I think having that background to know that we can use tone to our advantage in certain things is important because it's not necessarily the worst thing in the world, even though obviously it's not the best thing in the world. The best thing in the world is for us to have normal tone and coordinated movement, but we can definitely work through and capitalize on whatever stage of recovery that we're in. So some very common high tone postures. So these aren't all the postures that we'll see. These are not your flexor synergies or extensor synergies that you may see, which just to make a comment there, synergies are typically a position or contraction of multiple muscles across a joint that happen when you attempt a movement. So for instance, you may see, this is kind of going off track a little bit, but if someone tries to show you or you try to show someone how to lift your arm and kind of the whole thing goes, so if I say, Ralph, lift your arm, let me see you lift your shoulder, sometimes it's not like you're not doing this. We're like, I'm just seeing shoulder movement. The arm, the whole wrist, the elbow ends up coming and things go with it. So it's almost like you can't lift your shoulder unless your elbow and your wrist go together. So if I said, okay, keep that elbow straight, keep your wrist relaxed, and just raise your arm, it wouldn't happen because of a synergy. So that's not specifically what I'm speaking about right now, but that is another aspect of tone that we see where it's difficult to isolate voluntary contraction amongst over just a specific joint versus elbow, wrist, and shoulder all working together to do one movement. Um, but a very common posture that you'll see in the upper body is this picture right here. So the shoulder is internally rotated. So if we're thinking internal versus external rotation, I always think with the elbow, internal would be this way. So the shoulder comes in and adducted. So it may be tucked a little closer to the body versus doesn't need to be crossing midline or crossing into the body, but it's not here, right? It's more inward toward the body, tight here versus if I were to try to stretch, this may be difficult. The elbow is typically flexed, so here instead of straight. Flexed elbow, adducted shoulder, internally rotated shoulder, wrist pronation and flexion, and finger flexion. So this is a very, very common position that we'll see. Sometimes it'll be a little bit more relaxed. Sometimes it can be completely tight here. And now with the lower body, I couldn't get a really good picture of this, but it's very common for the leg to come inward, for the knee to be a little bit bent, and the ankle to be pointed downward and turned inward. So almost like if you're pointing towards the opposite foot. okay? Versus dorsiflexion eversion, it's plantar flexion inversion, so pointing inward toward the body. Now, go ahead, Ralph.
You want to stay out of those patterns, correct?
Yes, yes.
You want to avoid a sling because a sling will keep you in that postured position. These are, to my understanding, these are things that you want to break.
Yes.
So there's one sling, the give more sling, that holds your arm down straight by the side, and that one's acceptable. Other than that, you want to have a brace, something that's pulling that shoulder in, not holding
Yes.
that arm in the opposite, I mean, in that postured position.
In that posture, yeah.
I have a couple of ankle exercises. One's inversion, like which of course, is moving both your ankles out. And the other one is called down and in, up and out. And if you point that toe and you have spasticity, you can trigger spasticity. And if you have a lot of spasticity or you're stuck in that position, you want to try and break that before you do that kind of exercise.
Yeah, yeah. So almost like preparatory exercises or stretches. Um, and that's definitely something, I mean, I'm just going to show you forward. We'll go through all this, Ralph,
Okay.
but that's
Oh,
included here.
I'm
You're
jumping.
like reading my mind. But I have things that you can do on your own, and that I do have some being mindful of positioning of the arm or the leg. But I'd like to just note this. This is something that many people get frustrated with. I've even had like parents of kids with cerebral palsy be very frustrated and concerned, where they see a worsening of tone one day and it's better another day. And when it's worse, sometimes people get concerned that something's going on or something bad is happening, but it's very common for tone to fluctuate. So just like how our energy levels can fluctuate or our performance on tasks can fluctuate throughout the day. So I always think when I go to the gym, some days I can run forever or I can just do things forever. I'm just like, I feel so good today. I'm just going. I don't have any pain. I feel like I got good breathing. Nothing's bothering me. Other days I go and I'm like, oh my God, I shouldn't even tried because you just feel, but there's nothing wrong. It's just one of those days where you're just not feeling up to it and your performance is less. So that's exactly kind of what happens with tone, that it can be impacted or changed based on different things that are going on in our life. So for instance, if you're tired, your tone might be worse. And it may not be, oh, I'm tired, like I need to take a nap. But it could be like, oh, I had a busy weekend and I really pushed myself yesterday, or I really pushed myself this weekend. And you start to notice that you have some increased tone going on or increased stiffness. If you're sick, you can even see a change in your tone where it could be a little bit increased. If you're giving more effort to something, if you're having higher levels of anxiety or stress, if and when you're exercising, it could be increased during exercise, just like how I was mentioning with the synergies, where the muscle becomes fatigued. So that kind of goes back to that fatigue idea. Different medications that you may be on. And it doesn't even have to be neuro-related medications. It could just be like, oh, you're on an antibiotic or you're taking an allergy medicine. Like our bodies are so sensitive. They're so resilient, but they can be so sensitive, especially our neurologic function, to anything that changes. A women with hormone changes, or if you're going through menopause or anything like that, where or a younger woman going through your cycle, your tone may be different depending on the whatever is going on in the body can really, really impact your tone. So I think a note here, kind of like the takeaway would be, don't freak out. One, it's normal, and don't be upset with yourself because it is normal. But I think making sure that you take note of when your tone is worse so that you can identify it and manage it within that moment. So if you are fatigued, okay, I'm recognizing that when I do this activity or if I push myself too much over the weekend, to either expect that on come Monday, I'm going to be more fatigued and have higher tone, or to kind of pace yourself more so that you don't end up going into higher tone. So it's just something to note so that you don't become frustrated. I think that's the most important thing where I coach my clients or my patients to say, don't become frustrated because it's not something that you necessarily have total control over, and to keep moving forward and kind of go from wherever you're at in that moment. I see Debbie, you have your hand up.
Hi, yeah.
Oh, can't hear you.
Um, her question's in the chat, says the tone travel from shoulder to elbow to wrist, and I can speak to that just briefly because mine traveled the opposite way. So generally, yes, but I'll let you, again, everybody's different, so.
Yeah, so I would just say that maybe not necessarily tone, but recovery in general usually happens proximal first to distal, just because of distance from brain to those areas. So the typically what we see is shoulder comes back first. Anything that's closer, so shoulder and hip, usually that strength or that recovery happens faster, which we can usually say relates to moving through Brunnstrom stages as well, right? So if we're thinking about time of recovery, if the time of recovery of my shoulder is quicker, I'm most likely going to move through Brunnstrom stages faster. However, like Ralph will touch on, it really all depends on the person. So we have typical and things that we usually see, like common ways of recovery, but it all really depends on where your infarct was. Because if you had an area, if we're thinking, I mean, I can show you guys a picture of the motor homunculus, which is, hold on.
It's always interesting.
Yep. Hold on, let me see if I can just share. I'll share Google. So in your brain, we have what's called the motor homunculus. I love this picture. Everyone can see my screen.
Yeah, but we're not seeing the homunculus.
Hold on. Do you see it now?
Uh, yeah, that's real different than the one I've ever seen with the big hands and the big.
So you've seen this one.
Ah, yeah, there you go.
This is basically if you were to take this and show the amount of brain space that takes up those areas. So within the brain, so here's your brain. There's these two strips, I call them the bacon strips, of our sensory cortex, where we receive information about that area of the body, and our motor cortex, so the motor cortex is more in the front, sensory is towards the back. Motor cortex is where we send out information to those areas for movement. So someone who has a middle cerebral artery stroke, carotid artery stroke, they typically have more impact along this area of the brain. So you can see like more so the side of the brain where face, hand, wrist, shoulder are um, are mapped in the brain. So if I were to say, okay, where is the part of the brain that's responsible for moving my hand? It would be here. Where's the part of my brain that's responsible for moving my leg? It would be here. So someone who has an MCA stroke, which is the middle cerebral artery, most common stroke that we see, that artery comes out in this area here. Okay. So if we're saying, just think if there is,
And basal ganglia, Dr. Sam?
basal
Basal
ganglia is
ganglia?
deep. Basal ganglia is a deep cortical structure. So you're not going to see that in this picture. I can show you another
Okay,
picture of that. But
thanks, Doc.
so MCA comes out in this area. Think about like if there was, I hate to say like an explosion. Wherever that explosion is, that's where you're going to see the most impact, right? So the closer you are to the explosion, the worse damage. So if the explosion happens here, we're going to see the most damage here. And as we get further away, we'll see less and less damage. So this is why someone with an MCA stroke most typically has the most impact or the worst deficits at hand and wrist and elbow and shoulder. but typically shoulder comes back first because it's the least impacted area. You see that? Same
Okay.
thing with the leg. A lot of people typically have, I mean, they can have some weakness because the whole hemisphere can be impacted, but look how far it is away from the initial area of explosion, right? So
Yeah.
it's least, something that is only slightly injured is going to heal faster than something that is majorly injured. So this area where wrist, hand, thumb, shoulder are closer to the site of explosion, right? So that initial area of damage. So they're going to be most impacted and take the longest time to recover. So that's where that typically comes from, where we have that common recovery process. But sometimes there are deeper structures of the MCA or deeper structures of a different artery. So for instance, maybe Ralph's was more so over here where the this part of the brain was more so impacted. So shoulder and elbow was closer to the site of explosion, and his hand and wrist came back first.
Right
Does that
thalamus.
make sense?
Hey,
Go ahead, Ralph.
mine was in my right thalamus.
Oh, right thalamus. Okay, so now that makes sense. So if let's see,
Wow, look at all those brain pictures.
lots of brains.
Yeah, there's that one.
Yeah, this is a good picture, I think. Um, I like this one because it kind of overlays the original picture that I showed you. Um, so remember where this was mouth and face, hand and wrist, shoulders up here, legs are down here. So Ralph's was in thalamus. Now, the thing about the thalamus, I don't want to say location this way, but what we see within the brain is the beginning of communication starts on the outer part of the brain, and there's tracks, or just think about wires that connect the brain all the way down through the thalamus into the spinal cord. So if his stroke within the thalamus, so there's a homunculus also within the thalamus and within all of these structures as well, his may have or must have been more so at the shoulder versus the hand and wrist. Same thing with, so your basal ganglia is a combination of a bunch of different structures. So the thalamus is separate, but this substantia nigra, subthalamic nucleus, putamen, globus pallidus, these all make up your basal ganglia. So basal ganglia is just like
Oh,
a
great.
word for like the subcortical group
A
of,
huge area.
say it again,
Sorry. A huge area.
a huge area.
A
Yes,
big
yeah, it
area.
is a big area. Where I call it
Thanks.
the gang. It's like the basal gang. It's a gang of different structures because it's not just one thing, because they all communicate together. So this is kind of like um look, millions of nerve cell bodies. So it's a huge spot, but it's more subcortical. So when we say cortex, we're thinking really just the surface of the brain, the outer casing, I guess you can say. Subcortical would be deeper structures of the brain.
All
Um,
right.
so it's all going to change depending on where your brain is, where your stroke has targeted. But if we're thinking of like the most common areas, so this is a good picture. The common areas that are impacted are really the cortical areas, where that primary motor cortex, or the area that is the primary area for movement, lies. But again, you could have stroke anywhere. Isn't that fun? So it really
Great fun.
like
Thanks.
so it really
Thank you
really
for that. I
depends on where
appreciate it.
the stroke is. Go ahead, you can say it
Thank
again.
you.
One more time.
No, thank you for that. I
Oh, of
appreciate it.
course.
I learned
course.
I learned something too. I thought the basal ganglia was one thing.
It's
No,
the gang, Ralph. It's a gang of stuff.
I'll never forget that. Well,
They are, Ralph, it's the thugs.
The thugs, she said. That's what it feels like, right? When you have an issue there, they're the thugs that you have to deal with.
and your explanation of the thalamus, 16 and a half years, I've been wondering because I was rolling my fingers at 3 or 4 months and took me over a year to get my shoulder all the way up.
Yeah. The
I tell
thalamus is actually a very, very interesting area of the brain. We call it the relay center because really every center communicates within it. It's kind of like the roundabout of the brain where you go into there and you figure out where you're going to go next. So many areas go there and crisscross intersect. Um, and then also a lot of things like proprioception land there. So being able to have your body awareness. There is very commonly thalamic pain syndrome because there's such a connection with I guess you can say like sensory awareness too, where your awareness of your body can be impacted. So it's very common to have like a central pain associated with strokes that occur in the thalamus as well. So it is a very intricate and kind of complicated area to have a brain versus like what I said with the MCA. How easy is that? Like, okay, if your stroke was here, it's going to affect your face. If your stroke is here, it's going to affect your legs. Thalamus is like, okay, this is like the craziest area. Everyone gets confused entering a roundabout. So that's basically the same thing.
Ralph,
We have another,
when
go ahead.
Go for
when
it.
I say I had a right thalamic hemorrhage with extension into midbrain and pons and a resultant basal ganglia infarct, you can understand why I've got kind of some pretty significant deficits.
Those are a lot of important areas.
Yep.
So real quick, there's one more question. Real quick, the takeaway from normally starts at the shoulder, works to the hand. A lot of people that out there that don't know a lot about stroke and they'll go by the book. I've run into several people who said, "Oh, my hand's kind of working a little bit, but it's supposed to happen from my shoulder to my elbow to my wrist to my hand, so I'll just wait." And the takeaway for me, and I think you'll agree, Samantha, is I tell people work what works. If you have
Yes.
any kind of movement at all, build on that movement. Then the book hits 90 or 95% of people. It may not be, you may not be following the common
Yeah.
recovery path. So work
Listen,
what.
I had a patient once. It will shock my mind. And, this is why neuro is so interesting to me. I had this one patient. She was flaccid. Like this arm did not move. And there is a thing called spontaneous recovery that we talk about where sometimes there's just swelling going on or something's going on. And then literally overnight, there's an improvement in function. It's nothing I did, but it just happens. She comes back into therapy the next day and she's moving her arm. I'm like, how the hell did that happen? And it's just like, there is no explanation for it. It's literally a phenomenon that typically if someone's flaccid, I'm not thinking that they're going to get things back for a little while because to me, that shows that there's a lot of damage to the area. This woman, next day, she's moving her freaking arm. I'm like, what the heck? What did you do overnight? Were you working in your sleep? Like, I don't know. So it really is amazing and it depends on the person. Um, and there are miracles and there's things that happen that we will never understand because the brain is really an amazing thing. And so is recovery. But we definitely want to use it as much as we possibly can because that kind of goes back to our neuroplasticity where you use it or you lose it. And if you use it, you'll improve it. So the more you use it and the more task specific everything is, you're actually using that hand, it's going to push you towards recovery more and more.
But
Every time you do something, it strengthens that pathway.
Got a question asking if there's any difference in recovery or tone with hemorrhagic type strokes, so I assume versus ischemic.
Ischemic. So, again, typically, if we're thinking about just the way that these strokes happen, hemorrhagic typically, because it's usually a big area and there's insult because of blood in the area, we're seeing deficits because of increased pressure and because blood is actually toxic to brain tissue. So, because of increased pressure, all those different things, you usually see very, very strong deficits. So, big impairment at first. But once blood resorbs or there's some sort of a craniotomy to get rid of the blood, usually things come back quick. So we see really devastating deficits at first and quick recovery because once the blood's gone, usually the tissue underneath isn't dead. It's just being compromised at the moment because it's being there's increased pressure in the area and because of like the toxic environment that's in, it's messing with communication. However, with an ischemic stroke, we're actually cutting off blood supply. So there really is an area of death. So infarct means, so just like a myocardial infarct, so your heart attacks, that's when an area of that organ dies. So there actually is death of tissue with an ischemic stroke versus with hemorrhagic stroke. You can have death of tissue with the hemorrhagic stroke, but it's not a 100% thing that always happens. So in an ischemic stroke, that area does die. And what happens is there's what we call a penumbra or an area of impacted tissue around it. So if you think of like the core of the earth as your infarct site and the rest of it being area that's compromised. So that's really the area that we can get back following stroke and during recovery is that penumbra area. So they can actually see the size of the penumbra or the area that's inflamed, impacted, damaged, but not dead following stroke on imaging. So depending on the size of that and how big that initial area of tissue death is, will really impact how much recovery you get because once something's dead, it's not coming back. But the area around it can come back and heal. So typically, ischemic strokes, they don't have as devastating impact at first, but recovery is not as good or quick as someone with hemorrhagic stroke. Now, that's the typical.
Yeah.
You can have a very, very, very small hemorrhagic stroke, or you can have a very, very small ischemic stroke and have no deficits, and a devastating hemorrhagic stroke where you have no improvement at all. But typically, we see quicker improvement with hemorrhagic because there's no actual area of cell death to bring it all together.
If people get appropriate treatment.
Yes, if they get appropriate treatment, for sure. I like that plug because that is that is huge to be able to get the right care
Because
is
I
so, so
didn't.
important.
I didn't. I was at the emergency room at the hospital. Well, I was seen by EMS within 10 minutes and at the hospital in less than 30 minutes. And I was taken to a community hospital, not a stroke center,
Yeah.
even though there was a comprehensive stroke center less than 5 miles away. And it asked to go to the stroke center. It was 8 years ago, so I don't know, what the circumstances were, but once they saw it was a hemorrhagic stroke, they couldn't do anything. They didn't do an MRI for 4 days. They did do a surgical consult, but it was a spinal surgeon, not a brain surgeon.
Mm.
Oh,
Important.
terrible. I'm so sorry.
Yeah.
But being your own best advocate and knowing what you need even following that, rehab wise, I'm sure helped you with your recovery because you seem like such a well-educated and whether it be because of um bad care that put you there or just being an advocate to begin with. I think that really speaks for itself that if you are educated prior or learn the hard way, pushing for yourself to get the best care or searching for the best care is so important. And sharing your story so that you're able to help others who have gone through or may their family members, someone will go through it in the future, is definitely so important.
Definitely.
So this is kind of like a conclusive slide. This is really our last slide. So we're going to take some time on it. Mainly because many of you probably have undergone this type of intervention before on the left, the rehab intervention, but then things that you can do on your own. So there is such thing as serial casting for someone who has tie tone. This is kind of like last resort because I mean, if we go through all of our neuroplastic principles and things that we harp on specifically in rehab, we want to use our bodies as much as possible. And casting ourselves limits your ability to use that arm or that, that leg, what ankle, whatever is being casted, it's going to limit your ability to do this. So this is really a technique that's done for people who have I would say very devastating strokes that maybe it will help with quality of life, caregiver burden. So for instance, I used to work with a young girl who was very, very she just had stroke after stroke, so many complications, and um her arm was very tight, her leg was very tight. It made it very difficult to take care of her from like a cleaning standpoint, dressing standpoint. So she may be someone that they serial cast. Or if you're kind of further along in your stroke and you really, your stroke recovery and you feel like you're not making much improvement, this is something you can speak to your doctor about. But there is a lot of downfall because you're basically casted to stretch that joint, the muscle over that joint for a long period of time. I'm sure you guys are probably on some sort of medication or have received medications before, so you can do your Botox injections, which are specific to a muscle or an area. So if you have very, very high tone in the biceps, very, very high tone in the gastroc or your calf muscle, your doctor may recommend a Botox injection to reduce that specific area of tone so that you can gain some more range of motion and strengthen within that new range of motion before it wears off. So that's one of the cons of the injections is they really only last for about 3 months and you have to continuously do it and it can be very painful because it goes directly into the muscle. But that is something that many people do undergo so that we can prevent things like contracture. So say we're in the first year of stroke, which we know, not that you can't have recovery following, but that's really where most recovery happens or the most quick recovery or like most dramatic recovery we'll see from like day 1 to day 30 or day 30 to day 90. You see a lot of changes within that area, that time. So if we want to capitalize on that high neuroplastic time, using something like an injection during that time will help us, be able to do more. However, many people are on just oral medications like an oral baclofen, gabapentin, some sort of like a muscle relaxer to just reduce overall tone. Now, the thing with something orally is it's going to the entire system. It's not just site specific. So it may reduce tone in an area that you want to reduce tone, like say your arm's really tight, but then it may take away the tone that you're using in your leg for walking. So you kind of, usually it's good, but there are some, cons to it as well. Also, because it is an oral medication, it can make you fatigued. It can make you have other side effects because it's going to the entire system. Now, people with very, very,
Dr. Sam,
say it one more time.
sorry, Dr. Sam,
Yes.
I was on baclofen and it affected my speech. I was fine. I had nothing wrong with my speech, but it affected my tongue and my mouth. So I was on it for probably about a week. I had to get off because, I'm still battling. Just as
Yeah.
an example for you. Sorry to interrupt.
No, you're completely right. I even had, so I struggle with headaches a lot, and I went to like a neurologist for it. She gave me like some sort of a muscle relaxer, and she said to take it at night. I swear, I woke up in the middle of the night and I was like, I could not move my body. I felt so like drunk and like drugged because it was supposed to, I never took it again. I was like, oh my God, what the heck did I just take? I felt like I took some sort of a like an actual drug. Like I was drugged with someone. But I woke up, I'm like, oh my God, I'm so disoriented. My arms feel so heavy because like um like Debbie mentioned, it affects different areas of your body. So it was meant to relax the tension in my head and in my neck, but it relaxed me too much that I couldn't even move with it. You know, I just felt weird and clumsy. So that's the downfall of the oral medications. However, you never know until you try. So, some people love it. There's all different types of it. So there's oral baclofen, there's gabapentin, some other types of muscle relaxers or downers, basically, that will relax the muscles. Different dosages or times of day that you can take it. So, again, I'm not a medical physician, so I don't know the dosing and dosage and all that stuff that's recommended. But again, I'm assuming it's as individualized as like your typical care would be.
Dr. Sam,
Yes.
I will send you a research paper after the meeting, but I would do some research into the lack of suitability for baclofen for post-stroke hypertonicity.
Oh, sure, definitely.
It
It's
is better
crazy because
suited
if this
for,
is that's like the main medication that everyone gets placed on.
yes, they do, and it's really not as suited for, it's better for muscle tightness of spinal origin
Spinal
versus
cord.
cerebral origin.
I actually did see something similar to that. I wonder if it's the same article that I just kind of breezed by, but you're
It's
right.
old.
Yeah, yeah. Unfortunately, we do have a lot of old school doctors that don't keep up with, or PTs that don't realize that there's changes. Um, but in addition to that, some people have such severe tone that they may have intrathecal baclofen, which is like a spinal pump. It gets placed, if you've heard people with baclofen pumps, that goes into the spinal cord, into the spinal canal, not the cord, sorry. It goes where it's going to be a more direct route of um, giving medication. It's almost like as if you were to get IV medication versus oral medication. It's just a quicker means of transport to the body. Um, there are such things as tendon releases too, but again, these are more for more severe cases where there's like a contracture going on where we really can't, we have tried everything non-invasively and we need some sort of a tendon release to lengthen that muscle to regain function. But again, with any type of surgery, any type of these big procedures, there's always that making sure that you're going through what the healing process is. I think there was actually someone in Stroke Buddies that asked about it, and I said, I'm pretty sure you're going to be non-weight bearing post surgery. And she's like, I don't want to be non-weight bearing. The doctor never told her that she was going to not be able to weight bear through her leg for 8 weeks, 16 weeks, something like that. Go ahead, Polly.
Yes, so Polly can talk on that.
Well, I did not have a tendon release. I went to Mayo Clinic and I had hyperselective neurectomy for spastic equinovarus foot and ankle. And so it's actually a nerve procedure where the surgeon goes in and traces the motor nerve throughout the lower leg, and he severed a percentage of the overactive nerve branches. So not only was I not non-weight bearing, I wore my AFO out of recovery, walked out of recovery, and flew home the next day. 4 days after surgery, I did my 6-minute walk test in PT.
Wow.
That's something, huh?
That's amazing. That's what you get from
And
Mayo Clinic.
I went from spastic equinocavovarus deformity, where my foot was folding up on itself and turning to the side, to able to place my heel on the ground.
That's absolutely amazing.
Yeah.
Now, knowing that, that's a huge indicator for someone wanting to get back, right? So seeing that recovery versus others that you can't be weight bearing, and that can set you back a lot in all your recovery. So knowing all of that and knowing the questions to ask your doctors if these are options for you is super important. Thank you
And
for
it
sharing
was,
that.
it is, and it's noted in my chart. As you were saying, it is a treatment of last resort.
Yes.
I have been through everything else.
Yep. Exactly.
Do your research, people.
Yeah. And like Polly said, she flew somewhere for that. You
Mayo.
want the best of the best. Okay, so PT wise, there is no cure to high tone and spasticity. There's management, and there's nothing that we're going to do to reduce tone long term. So there's no curing of it from a rehab perspective. Like Polly was basically cured of it. There's nothing we can do from a PT standpoint that's going to reduce tone long term, except for recovery and all those different strategies, right? However, there are many things that we do to try to reduce, to improve comfort, to reduce any pain that you may have, reduce the stiffness, and kind of prep your body so that we're able to do other things during your session. So like we were kind of, me and Ralph was bringing up before, stretching and doing those prep activities are huge things that we do prior to therapy so that we're able to get the benefits of reduced tone and participate in functional tasks. So for instance, we may work on some lower body stretching, some weight bearing activities, use of neuromuscular electrical stimulation to allow for better weight bearing, to allow for better heel strike when we're walking, standing. I love when Ralph does that. He shows that his cup is empty. It's my favorite. It's like his signature thing. Um, so there's a lot of things that we can do that reduce tone because say, for instance, you have a very tight ankle and we're not getting really good heel contact when we're walking. Or, that's going to limit your weight bearing through that leg. That's going to limit the amount of time that you're able to stand for or the symmetry between left and right when you're weight bearing. It's going to impact your ability to do the stairs, impact your ability to walk. So if we're able to reduce that tone and kind of stretch and relax and get better, almost like ankle neutral with some prep activities, we will do that so that we're able to get more benefit out of the things that we're actually doing during therapy. Now there are places that do aquatic therapy. Some rehab centers that have it, even just some community pools that run aquatic therapy programs or just aquatic, just swimming classes where the water is so therapeutic for something like tone because it does provide some extra input to the body, but that warmth of the water really does relax you and can allow for better movement and weight bearing because of just being within the pool. So something like aquatic therapy, it can be straight up physical therapy, but it also can just be something that you receive from someone else. But if you have the means and feel comfortable going into a pool yourself at a community center, that's something that you can also do on your own. Things that you learned from your therapist or you've learned on your own that kind of help stretching and maintaining different positions so that we can prevent contractures and that we can get good movement over those joints are very important. So this kind of lays and goes along with the being mindful of positioning and uses of splints or braces. So there are occupational therapists typically do this, but PTs can also do it depending on like where they are or how the system that they're working in works, where they can make splints for you so that, you know, certain parts of the day, your hand or your wrist or your foot are in a better position at rest. Or when you're sleeping or relaxing to have your arm propped away from you and abducted to the side so that you don't get tightness within the lat muscle or within the elbow. And preventing your arm from going into positions for long periods of time that are going to increase or kind of put the arm in the bad position for a long period of time. So this is when Ralph was talking about the splints, not the splints, the slings, where if you're wearing a regular sling, a lot of people who have low tone have subluxation of the shoulder. So they want to wear a sling to support the shoulder. However, if you're in a sling that's holding the arm in your flexed tone posture, you're just letting that arm rest in a really, really tight posture for a long period of time, which is not what we want. So there are other slings like a give more sling, proximal shoulder support, where you're able to get subluxation support at the shoulder without having to place the elbow and the wrist in a bad position. There also are some AFOs that you can wear or overnight bracing that can be worn to make sure that we're maintaining better positioning at ankle during rest. Go ahead. Who is talking?
I think it's noise.
Oh, okay. So,
While we're quiet, I'll ask a quick question.
sure.
Sorry, I know it's hard to hear me. Can you hear me okay?
Yes,
Yep.
yes.
I want to find out, is increased tone the cause of nerve pain? Nerve pain. Because I had nerve pain, chronic nerve pain in my arm for 3 months. And it has gone away now, but I'm curious to know.
Not typically because of tone. Tone will really more so hurt when you're trying to do a stretch or trying to use the muscle. Typically like right at the tendon area. So like biceps wise, you'll feel it right here or right at the shoulder where it attaches to the bone. But you can definitely have post-stroke pain in general or like a central type of a pain because of just the recovery of the nerves and the connection between brain and body. Also almost like a phantom limb pain where like the brain is thinking that something's wrong with the arm because it's not moving. So there are a bunch of reasons for post-stroke pain. In your case, I'm thinking it's not due to contraction. It's not due to tone because of the way that it's described. It's
Okay,
usually
no,
when we
mine
see some
was
stretching or positioning changes that you'll get the the tone,
because I have, okay, I have full connection, full feeling, and every time I did anything, movement, whatever, I had pain in my shoulder, in my elbow, from there down. It was insane, but proper pinching pain.
Yeah, that sounds more like a chronic pain syndrome that's related to just stroke recovery, not related to tone.
Okay. Okay, thank you.
Yeah. Okay, let's see what else. So other things you can do. So as I was saying, there are like ankle orthoses or braces that can be worn. So there are so say you have spasticity or you do have higher tone in the ankle and it's limiting your ability to walk, your orthotist and physical therapist can work together to develop and prescribe you an orthotic that reduces spasticity or clonus during walking, or um, helps the ankle go into a better position when you are walking so that you're able to weight bear properly and like move through the phases of gait properly. But there also are just resting splints at night where the ankle is kind of placed into neutral dorsiflexion. So it's just in that neutral position rather than being in a pointed down position that's going to increase like the tone within the calf muscle. And then of course, all the other things that we can kind of pay attention to. So reducing any stressors that we feel like are increasing our tone. And then using our medications properly. So making sure that you're keeping up with your medication management, keeping up with appointments so for instance, like if you're going for Botox appointments, making sure you're staying on, that track and knowing, okay, every 3 months is kind of when I need to go back for that. So let me make sure that I keep those appointments in check so that I can manage the tone properly. Or, for instance, if you're seeing a change or some negative impact of your medication, saying to your doctor, having that collaboration and the advocating for yourself so that you're able to get the best out of the medication that you're given. So you really just need to, I usually like recommend like just have a journal for when, or put it in your notes section on your phone so that you can kind of keep in mind, okay, on this day, really crappy weather outside, had a long weekend, I'm getting bad tone. Or, I'm really stressed out about something, my tone's worse. Because if we're able to target all of those extraneous factors that are increasing your tone, you'll have a better kind of handle on um, reducing it and taking advantage of when you do have lesser symptoms. But that's about it, everybody. Does anyone have any questions? I know we always like to chat following.
I have a question.
Sure.
How do you relate with heat? You said apply heat, but how do you relate to heat?
So the heat will just work just like as a muscle relaxer. So just like if you have, a tight muscle because of like you've got like a tight neck or you hurt your back, the heat allows the muscle to relax. So if you have high tone and you're placing a little bit heat on it, it's a good prep activity. Or if you're having a little bit of pain, it can reduce the tension and the discomfort in that muscle. We always just say be mindful of heat directly on the skin. Um, Applying heat as a modality is actually a skilled thing within the physical therapy profession because of the risks of burning and making sure that we're not overheating, especially if you have an insensate arm that you don't feel temperature as well. So being mindful of checking the skin, checking for redness, or even just layering that heat properly. So for instance, if you were to go to physical therapy and they place a heat pack on you, moist heat that you see from the hydroculator, they pull that thing out, they put it in those pads, you should really have 6 to 8 layers of towel or something on top of that heat when it's being placed on you to protect you. And even with that, you still need to be able to monitor. So being very, very careful if you are applying heat. is the most important thing. I just always say make sure that there's some sort of a barrier between skin and the actual heating device. Check every 5 minutes or so.
Okay, I have another question.
Sure.
Every night when I sleep, I to help my shoulder, I put a pillow under my affected arm. Is that a good idea?
That's completely fine. Because that's going to keep the arm out and away from the body versus really, really close. And it protects the arm and kind of gives it a barrier so that it's not getting in and squished. Because what happens is, I mean, we can't really control the way that we move within our sleep, but at least if the arm for most of the night is protected in a good position, it's good. Um, Even if you're sitting and watching TV, sitting in a wheelchair, sitting at the table, making sure that arm is in a good position and not lost, because like I said, with the decrease in sensation, decrease in body awareness, decrease in feeling, you may like forget about that arm and it's just either like squished somewhere, tight somewhere, just always having like almost like that little alert in the back of your mind to think, okay, wait, let me just make sure my arm is good before I do something else.
I got one.
Sure.
I'm hoping to learn something here because you mentioned clonus a couple times, and I mean, I suppose clonus is, well, I'll let you explain it. I didn't really think about it. I think about it in terms of like uncontrolled repetitive motion. I had it, well, I think that's what it was. It's kind of ill-defined as to what it is. So I guess I'm going to ask you to talk a little bit about clonus and how it relates to spasticity. I had it a little bit in the beginning, particularly in the morning, well, at night when I was sleeping, or particularly in the morning when I woke up, my arm used to lap the bed, and it was hard. In the beginning, I couldn't control it. I held it down, and then I actually learned how to stop it with my brain, and it actually went away. Took a while.
Yeah, so you may be talking about two things, Ralph. So clonus is similar to spasticity, where spasticity and clonus trigger an abnormal reflex response. So like when you do a deep tendon reflex at your doctor and they hit your knee and your leg goes, they hit it with that little hammer and your knee is supposed to, jut out involuntarily. That's kind of what spasticity and clonus do in an abnormal way, where they're triggering a reflex of contraction due to a stimulus that shouldn't really be causing a contraction. So when you're doing a quick stretch, so if I quickly stretch my bicep, I get a contraction of the muscle involuntarily. So it's a reflex to contract a muscle in an abnormal way. Now, clonus is very similar, but it ends up being a beat. So clonus will have to happen due to a quick passive stretch that where the muscle that's being stretched, instead of just resisting, it beats in the opposite direction against that stimulation of a stretch. Typically happens at the wrist and happens at the ankle. But we can get it in the hamstrings. You can get it anywhere. It's just more typical at the wrist and ankle, where if you do a passive stretch of those muscles, you can either get just the resistance of the muscle or you get the beating. Now, what I think you're talking about, it may be just resting tremor, where the muscle is just involuntary contracting at rest. Because what you're mentioning is there's no passive stretch that's happening. So again, just an abnormal type of tone or muscle contraction that's following stroke because of the damage to the central nervous system. Just the main difference between something like a resting tremor and a like clonus or spasticity is that velocity dependent passive stretch to the muscle. Specifically because you're a deep brain structure stroke, that's more likely to happen when you have a resting tremor. Just think people who have Parkinson's disease, their deficits or issues within their brain are basal ganglia. So that's a deep brain structure, and one of the hallmark signs of Parkinson's is resting tremor. So because of the location of your stroke being subcortical, deeper brain structures, it can have something related to that where you get those resting tremors, where if you were to hold it, it can relax the muscle. Or it's kind of like, I don't know if you've ever had like a knot released in your neck where like if you push on the knot, it ends up releasing and feeling good. It's a way to kind of just calm the muscle and relax the muscle tissue. So that's kind of like what you were doing when you were to hold the hand or hold the leg to calm down that, to me, what seems like tremor more.
Thanks. What I did was in the beginning, I would hold it down, hold it tight. And then I started saying, wonder if I could like not hold down so tight and try and hold it down with my hand. And I went through that, and as I went through that progression, I started wondering, as it got better, I started wondering, I wonder if I learn how to, if I'll be able to learn how to stop this, and if I actually learn how to stop it, will it stop on its own? And in my case, can't say for anybody else, in my case, I did learn, took, 6 months or a year, but I did learn how to stop it. And when it would happen, I could stop it with my brain without my other hand. And eventually, after uh, another 6 months of that, it pretty much went away. About every,
Wow.
about every 3 or 4 months, I'll get it. And I just can, like, I don't have to look at it, but I just look at it and stop it.
Yeah.
You may, it's like anything else in recovery, give it a try. You never know what's going to work.
Yeah. Yeah.
I pull around with everything.
For sure. The mind is definitely a powerful thing. And it almost is like like an outer body thing where, when you start to have pain, but the body's not in pain, and you just continuously tell yourself, you're not in pain, you're okay. And that kind of retrains the brain to understand, okay, even though I'm trying to move, I don't need to move right now. Or, there is no insult to my body. There's no reason for me to have pain, because there is such a psychological impact of thought process on feelings of or movement, like for instance, with stress, you can have increased heightened symptoms of heart palpitations, headache, shortness of breath. And it's a real physiologic response to stress in the brain. But you can calm yourself down with calming mechanisms or just positive thought. So there really is such a psychological connection between mind and body that I'm sure what you were doing it wasn't just lucky. It really did work and help you.
Well, no, it's, because as you know, there's mental imagery or mental practice.
Mhm.
And I got my hand open that way. So I was already open to the idea that I could somehow use my brain to work on correcting a problem. So that's
Yeah.
why when I had it with my arm, I just looked to that same kind of solution because it had worked in opening up my hand.
Yeah, for sure.
One more thing I'd love for you to clear up. Uh, well, first of all, I know spasticity is often velocity based. We had a physical therapist who has it and who demonstrated how it works in his own arm. He had a stroke at 6 and became a physical therapist. Interesting story. Um, I never had anything. I never experienced anything where I got increased spasticity due to any kind of quick movement. So it's not. I guess it's not always velocity based. The other thing you mentioned was the little red rubber hammer a minute or two ago. Also, what I noticed is I did a lot of stretching. I did like passive movement. I rested my elbow on the edge of the couch or sofa and let the weight of my hand help open up. So I did a lot of passive movement and stretching and stuff. And then as I got more range of motion back, I worked on building up strength throughout their range of motion by doing exercises, specific, exercises in case of the arm, curls and things like that, pulling on TheraBands, different ways.
Mm-hmm.
And what I found was the more greater range of motion I had, and the stronger I got throughout the range of motion, and also get rid of any bumps. I had like a bump, like right here, and again, I just applied logic to the whole thing. I actually would work like right around the bump until I could get rid of it, and then I'd go back to doing the bigger range of motion, and the bump would come back, and I'd work on the bump. Eventually, the bumps went away. I can actually make it come back if I want, but I don't want to. Anyway, I found as I went through that whole process and got pretty strong throughout the range of motion that my spasticity pretty much went away.
Mm-hmm.
So I was a little confused by when you said something about, as physical therapists, we can't reduce spasticity long term. I actually did a Botox study with a doctor a neurologist at MUSC, Medical University of South Carolina. And when I first met him, I walked into his office and he looked at me and he said, "Would you mind walking up and down my office a few times?" And I sure. So I did. And he said, "Would you mind if I examined you?" And I said, "No." And he came over with a little rubber hammer and he hit me different places and stuff. And he said, "You have no spasticity." I said, "Yeah, I don't think so." He said, "How did you do that?" And I said, "Exercises in a range of motion." So,
Yeah, for sure. So there are things that are going to improve it, but I just like to preface it as we're not that there's no guarantee, but it's not that we know that with strengthening of a muscle, it will get stronger. It really is so, it's kind of like an obscure topic where sometimes there is a reduction in tone and sometimes there's not. So we really don't like to make that promise of this is what's going to reduce your tone, because the thing is, I can, for instance, someone with like cerebral palsy. Basically, cerebral palsy is a stroke or injury to the brain that happens when a child is young, between the ages of being within the womb to 2 years old. So it's very similar presentation as stroke would be. I can stretch one kid in the beginning of a session, I could see him for a year. His tone will be the same because there's some sort of a um, long-term injury to the brain that's reducing my ability to improve range of motion. However, prepping activities will help me with improving other functions that we do. So we'll do some prep work in the beginning, and then walking and whatever functional activities that we work on throughout the session will be easier, or we'll be able to push a little bit further because we have that extra range. So similar to what you said, that if you work within a range of motion and you start to gain more range of motion, you're able to strengthen within that range of motion, right? So if, I start here and then eventually I'm able to stretch and get their arm here, now we can strengthen in this whole range instead of right here. So those are things that we're able to do. And with long-term progress or long-term use of like that type of method, the tone should be able to reduce. It's just not like a proven thing with research that it's going to get there. But there are scenarios where it does definitely work.
okay, I understand.
Ralph,
Yeah,
when you were talking about your bump,
yeah.
that sounds like textbook spasticity. You were moving your arm and it caught, and that's exactly what happens.
Well, except I'm moving it slow. I mean, okay. Yeah, well, I definitely had a bump right here, right in between there and there. I had like a 1 pound weight. Actually, I started with no weights. I'm a big believer in repetition and not a lot of heavy weights. John's nodding his head because I think he found the same thing to be true in his case. So Polly, what is that? What do you call that? That's a presentation of spasticity?
Yes, that's the catch, the velocity dependent catch.
Okay.
So what I think I would say the difference between it is that you have to have some good speed, but some people's tone is more, or spasticity is more, what's the word? Sensitive than others, where you really have to move fast to get the tone to increase, and others you can move slow. Or it could just be a passive because you were moving the arm slow, it could have just been a passive, um, what's the word? Like the catch could be a restriction to passive movement. So it's kind of like a block to passive movement. So it could be either one of those, where it was just a higher tone that we're picking up with passive movement because you were moving so slow, or it could be that your arm was very, very sensitive to stretching in the opposite direction.
Ralph, did it happen if you passively moved your arm or just actively?
Actively.
So yeah, that's spasticity should happen passively or actively.
Yeah. So it also could be
Actually felt
almost
like
like a sometimes we can see, I don't really know what we would call it, but sometimes what happens is it's almost like the muscle begins to spasm. So I don't want to say like spasticity, but when you're trying to use it, it contracts involuntarily at the wrong time. So you almost get like a cramp in an area where the muscle's trying to control relaxing. It's almost like a coordination thing where the muscle, instead of it slowly relaxing nicely and slowly contracting nicely, it kind of gets there's like a misfiring that can happen. So it's kind of hard to describe and like really tack down what it possibly is. But I think kind of take home message is that Ralph is very good at identifying the things that are going on in his body. He's very body aware, and that helps him and can help anyone really target the deficits that they have so that you're able to move past it or work through it. So, some people, they'll come to you and you'll try to do that for them. They're like, oh, I never even realized that happened to me. Or that even was a thing, that when I would stretch my arm or move my arm, I'd get a little bit of a tightness there. So, I think kind of like take home would be the more aware you are of your body and the better you know your body, the better we're able to tackle things that are going on. But I have to say, Polly, I love your shirt. It's perfect for the day.
Thank you. I wanted to make sure you saw it. And I did want to say that yes, I had the surgery for foot and ankle, but that's one joint.
Mm-hmm.
And so since I am affected throughout the left side of my body, after surgery, I spent 9 months in PT.
Yeah.
So it's, yes, did it, and just me personally, there's someone who had the surgery who 6 weeks after surgery was cross-country skiing and hiking in the mountains without an AFO, just, off living her best life. For me, because of other complications, which I can say to you, intrinsic spasticity, and you will understand, I still have curled toes, and in my arm, I still have curled fingers and still need botulinum toxin injections to help manage that because of that intrinsic spasticity.
Yes.
So I'm not a good poster. I'm a poster child of someone who really has some significant deficits.
And I think not only significant deficits, but is a very motivated person who tries everything. And you're
Oh yeah,
committed to it. You're committed to your recovery.
I am. I do neuropersonal training 3 times a week. I do the FES cycle 5 times a week, and
Beautiful.
I volunteer on the weekends. So
I love it. So you are a poster child for those things.
yes, but I hesitate, somebody who looks at me walking and say, you said you had that surgery and it really was helpful. It's like, yes, but I'm kind of an outlier case. And I think the woman who was cross-country skiing 6 weeks after the surgery was the outlier on the other end. You know,
Yes.
for most people, it's somewhere in the middle. Definitely improved quality of life, improved ambulation.
Yes. That kind of just goes back to every case is different, right?
When I ask you about the, getting rid of long term, I get asked, do you think I'll get better? And my answer is always, if you work at getting better, you'll get better than you are, and nobody can tell whether you're going to get better or not.
Yeah.
So, and one thing we can tell you is if you don't work on getting better, you will not get better. So outside that 6 month or year, whatever it is, spontaneous healing
Yeah.
process,
And I
typically.
think there's always that idea of knowing that what is better to you? What are you classifying or quantifying as what better is? And it may not be recovery of strength or recovery of improving tone, but it can be improvement in quality of life, improvement in safety, improvement in balance, and dealing with whatever deficits are long term, dealing with them and living with them in a way that doesn't restrict you from doing what you want to do. So, for instance, if you are dealing with some significant long-term tone or hemiparesis in the ankle, making sure we get the right AFO, strengthening all other muscles that we can, improving your balance despite that deficit, and challenging the goals that you may want to do with like long distance walking or something like that. Kind of like I kind of have been recently, we've been doing a research study at the VA right now with blind low vision patients, and it's amazing to see the difference in function between some and the other. And it's not that his vision is worse than his vision. It's who has remained active and who has continued to challenge themselves and strengthen all the other systems within the body, even though they can't get their vision back. So, say for instance, you can't get your strength back or you can't get the return of your hand back, but there's a million other parts of your body that we can still improve. So, there is still improvement. It's just where are we tracking the improvement, right? And how are we measuring it?
So a variation again of work what works.
Yeah. Yeah.
Work on what's improving. If you're not improving somewhere, also, but we're back to breaking things down into subtasks so that you're
Yes.
not trying to do the entire thing at, right out of the gate, which is something I did. I thought it was cheating to not do it like the way the sheet said, and I got real frustrated because, of course, I had hemiplegia and I couldn't do some of it. And I learned
Yeah.
an important lesson, which is a lot of times it's real useful to, or all the time, I would say it's useful to break things down into the parts, work on all the parts, and then try and put it back together.
Yep. That's what we call part to whole practice.
I don't know any of the terms. I didn't know anything about stroke, but and I'll just say to people out there, body awareness goes a long way. I had a lot of it naturally, maybe because I don't know if it's innate or can develop it. I fooled around with muscles instead of doing my homework when I was in high school. I used to go up and wiggle my ears. Uh, and fool around with muscles. So maybe I developed it. But if you can develop it, I would highly recommend body awareness. If it's slow going for you, I would simply recommend paying attention. What you're saying is, about your patient coming in and go, oh, I didn't know that. It's really a more of a
Paying
pay
attention.
attention thing. It's the beginning of body awareness.
Yeah.
John's nodding his head because he's learned. Some of us learn these lessons the hard way. Polly has too, of course. Well, all of
Yep.
us.
And I would say be gentle toward each other. I went from 5 years completely insensate. So, as you can imagine, with no proprioception, with no feeling in my arm or leg, it's difficult to walk, much less get, good return of movement and muscles. To the past, I guess it's working on 3 year, well, 2 years now. thalamic pain syndrome. So my reward for, getting back sensation was thalamic pain syndrome. So
It's always
just
something,
be
right? But
gentle with each other. Yeah.
yes, I agree, Polly.
All right, well, we've taken up a bunch of your time today.
That's completely okay.
We
I
really,
love chatting with you guys.
well, we love the fact that you are so knowledgeable and willing to give back because it makes a big difference. And, it makes a big difference to more than just the 14 people or whatever we had here today, because like your last presentation had some like 75 people watching it on YouTube Live, and now the video's got 300 views. So,
Yeah.
what you do is impacting more than the faces that you're seeing here, right?
Thank you, Ralph. Thank you. And it wouldn't be we wouldn't be possible without you.
But I want to make sure everybody out in YouTube land or live, and when I edit this and put it up, it knows that all your contact information will be in the description underneath the video if you got questions or want to reach out to Dr. Sam. I'm always careful to make sure I recognize people. When we talk, I just call you Samantha or Sam.
That's completely okay. You can call me Sam too. White coat syndrome. There's no white coat syndrome here. I'm just a regular person.
I try and be respectful because you went to school for a while to get that white coat.
Thank you. Thank you.
Well, no, thank you for taking the time and sharing this. John, you got something?
No, just gonna say our thanks.
Oh, okay.
Thanks, John. Thanks, John. Happy to have you.
I was glad to be here.
Thanks,
for a change.
Dr. Sam.
You're very, very welcome.
Do all you can with what you have, in the time you have, in the place you are. Do all you can. Do all you can.